Welcome. This edition of the Perspectives of Inflammation podcast, a series brought to you by the CSF, which shines a spotlight onto experts in the field of inflammation and their research interests. My name is Professor Michael Weinblatt from the Brigham and Women's Hospital in Boston, and joining me today is my good friend, Professor Paul Emery from the University of Leeds, UK. Welcome, Paul.
Thank you, Michael.
So, Paul, you've been at Leeds for almost 30 years, since 1995. And under your stewardship, it has grown into a world-leading center for rheumatology research. Could you tell us a little bit about the unit and its key areas of research?
Thank you, Michael. I went to Leeds because basically of the patient groups there. We have a secondary care population which we look after universally for about 1.5 million, and a tertiary population around 5 million. Which means we have to provide everything. And from the start there, my priority was getting well-defined phenotyped cohorts, initially in inflammatory arthritis, but now covering all the immune-mediated inflammatory diseases, lupus, scleroderma, psoriasis, psoriatic arthritis, Sjögren's syndrome. And basically, in the inflammatory arthritis program, we study these patients. We've been involved in a lot of investigator-initiated studies with new therapies. The other side of it is that I'm director of the biomedical center there, which the NHS funds for research, and we do a lot of work with medical devices, joint replacements. We have a very big program there, and also in osteoarthritis.
So, Paul, can you tell the group a little bit about what drew you into rheumatology and where you moved before you got to Leeds?
Yeah, sure. What drew me to rheumatology basically was seeing patients long term. I had intended to be a cardiologist, but it was very contrasting, the fact that you looked at an angiogram and never really spent much time with the patient. Whereas the rheumatology patients were amazingly grateful for your attention. And also it was clear to me that most of these were reversible diseases. At the time, we only had steroids, but as you know, later we developed what were essentially targeted steroids, which allowed the same benefits without the toxicity. We didn't know that was going to occur, but I did feel there was a large chance that we would see major developments in rheumatology. So I did that after coming down from Cambridge at Guy's, and we set up early arthritis clinics there, which were very poorly attended, actually. It was very difficult to get patients. I then went to Melbourne and did more early arthritis with a bit more success. But it was when I went to Birmingham that we really set about seeing patients early, because we were convinced that if we could see them early, even with the drugs we had available then, we would be able to do something about preventing damage. And we spent a lot of time when I set up the unit there, phoning up to 3,000 GPs, writing to them continuously, telling them that we would see patients urgently. And when I went there, we had a waiting list of 18 months before we could see a new patient. And we got that down to 3 months over a period of about a year. And that's what we've been aiming at since, to try and see patients at the earliest phase of disease.
And I would like to explore a little bit more this issue of the early arthritis clinics. Before I do that, when you were in training in your early development, were there a couple key rheumatologists who mentored you along or provide you inspiration on your career?
I suppose the most influential person was Gabriel Panayi, who was at the time quite a revolutionary in rheumatology. He came from a scientific background, and rheumatology up until then had been aligned with rehabilitation and was basically tuned into alleviating pain and managing chronicity. Whereas Gabriel was very keen to intervene to make a difference and understand the pathophysiology. And it was that drew me to rheumatology.
So when you went to Leeds and really started moving forward with the early arthritis clinics, was part of that due to the, as you mentioned, the huge waiting lists to get to see a rheumatologist, and partly due to the fact that you thought that starting people earlier on drug therapy would make a difference?
Well, it was the latter. It was trying to see patients early. And in Birmingham, we actually had a very large early arthritis clinic, and most of the guys and the nurses came with me when I went to Leeds, actually. So we sort of hit the ground running in Leeds. But yeah, since that time, fortunately, I think it's become accepted practice to see patients early. And now the reimbursement from the government is dependent on starting, or the optimum reimbursement is dependent on starting patients in the first few weeks of disease. And I think everyone now believes that that is the correct thing to do, because you can do it before damage. There's been arguments about the window of opportunity and whether you really make a qualitative difference early. There are now some data that suggest that the numbers you get into drug-free remission are very dependent on that early phase of disease.
How good are the primary care doctors now, and as far as referring you patients that actually have inflammatory arthritis versus those that have fibromyalgia or osteoarthritis?
Well, obviously, that's the key question. And when we first started, we had fairly strict rules. They had to have a swollen joint. They had to have positive serology. As we got greater capacity, we were happier to see patients who had symptoms, in other words, stiffness in the hands and the feet. And it depends on how much facility you have, what capacity you have to see patients. What is interesting, you can make a lot of difference to a lot of patients, even if they have non-inflammatory disease or inflammatory disease that's not rheumatoid. So now we have a greater capacity. We are quite happy to see other patients because you can manage them quite quickly. But our priority is inflammatory disease, and primary care is the key. We spent years telling GPs that arthritis was potentially treatable, and that not to go on prescribing repeat prescriptions of anti-inflammatory drugs, because if they were working, there was probably inflammation present. But now we spend our time getting GPs to actually test for ACPA or CCP, and we see patients before they get synovitis, which is our big program these days.
And going forward, looking at your impressive CV, obviously one big area has been the concept not just of early intervention, but treat to target and reducing disease activity. You were one of the first to actually incorporate remission criteria or remission definition into clinical trials with the COMET program. Do you think our current definition of clinical remission is viable today, and can we induce that in most of our patients?
Well, as you know as well as anybody, Mike, the old definitions using DAS-ESR or DAS-CRP incorporate abnormalities that we wouldn't normally consider as remission, and more stringent criteria used. We try and use the most objective criteria, and we use traditionally imaging in all our patients, either MRI or more commonly ultrasound, and that's made a big difference. I don't think most people would call patients in remission these days if they had very florid synovitis, regardless of their clinical features. The trouble is that all the composite definitions include joint counts, and in near remission, joint counts aren't very accurate. So we incorporate not only imaging, but also immunological parameters, and we found those very helpful, particularly when you come to tapering therapy. You can't taper therapy if there's underlying active disease, that becomes active. And remission is certainly the target of all our therapies. It's surprising, patients treated in a standard fashion, how poorly they still do. The fit patients that go into studies do pretty well, but we get a lot of comorbidity or multimorbidity, and often the limiting factor is what these patients will tolerate in terms of drug therapy.
Paul, one of the questions I think we all want to know is your view about, since you've identified that even though patients may have improvement or resolution of their painful and swollen joints on ultrasound, many of these patients still show, or MRI, still show evidence of synovitis. Are you at a point now where you are adjusting drug therapy in someone who's got no swollen joints but still has ultrasound evidence of disease? What do you do in those patients?
Well, it depends what they're taking. If they're taking a drug which probably isn't as effective on the cartilage and bone, then we might add, and often we just inject the joints, actually, to be honest. If they're on one of the biologics, which are pretty effective at inhibiting any damage, I think you've got to think very hard before escalating therapy. If they're well, their quality of life is good, and even if they have got subclinical swollen joints, as you know, there are a number of studies. We've just reviewed several of them. There is quite a good study which has actually just shown that from Norway, that if you have subclinical osteitis on MRI, despite being clinically normal, escalation of therapy in those patients actually produces much better long-term remission. So in an optimal world, you would actually tailor it to the individual. Obviously, with huge numbers of patients, you have to actually work out what's most cost efficient for the patient and society.
Today we're blessed by having an incredible number of novel therapies, not even novel anymore, 20 years since the TNFs were introduced. In clinical practice, how do you make a decision about which drug mechanism you're going to go to, whether it's one of the injectable therapies, one of the biologics, whether it's one of the new oral therapies, the JAK inhibitors? Do you have any bias about that? Or does the government tell you what to do?
It is now one of the biggest questions. If you are not going to be satisfactory on conventional synthetic DMARDs, where should you go? I'd turn it around a little bit. We're increasingly trying to predict non-response to the conventional synthetics before patients actually fail them, in which case there would be first-line agents. And I think first-line agents, if you're using either targeted synthetics or the biologics, the questions we have as a nationally funded group is what is the most cost-effective. And at the moment, we're very lucky with very cheap biosimilars. So our bias at the moment is to go to the biosimilar TNFs as first line. When we're giving them after methotrexate failure, you're looking more at getting efficacy, and there are arguments in favor of the JAK inhibitors then. The well-known issues with the JAK inhibitors, some of which are going to be soluble, like shingles, herpes zoster with the vaccines. And I think the case for the vaccines is getting quite strong now. We don't have Shingrix here yet. It's approved in Europe, but we don't have access to it. But we're hoping to be starting studies of that. And I think that will come as routine in future. And I suspect patients, when they get diagnosed, will get the vaccine in the future. So it's complex. And I think we're lucky. We have these alternatives. We still have a large number of patients who have failed huge numbers of DMARDs, sometimes 3 JAK inhibitors these days, and they are complex, which is all the more relevant why we try increasingly to see patients almost before disease, because we know they do even better than the ones treated after 6 weeks.
And you've worked with all of the JAK inhibitors that are approved to date. Where do you see their role in 5 years from now?
Well, they are very effective as first-line agents. I think if we can, the issue of thromboembolism still hasn't been sorted out. We know the high risk factors for those, but the high risk factors include many of the features of rheumatoid arthritis: high disease activity, obesity, smoking, and steroid use as well. But I think we will target much more the therapies to the individual characteristics of the patients.
And what about, one of the exciting things I think about the JAK inhibitors, very much like the TNF inhibitors, is their potential use in a variety of diseases. If you had to look outside of rheumatoid arthritis and angst-spawn and PSA, where do you think the JAK inhibitors might play a potential role?
Yeah, you're right, Mike, because they have this widespread effect through their mode of action on multiple enzymes, and the patients who have multi-diseases, let alone multi-morbidity, are clearly ones who would benefit it. Patients with psoriatic arthritis, with bad skin and bad joints, who sort of alternate between 17 inhibitors and TNF inhibitors. They're clearly the ones, and also people with bowel disease, uveitis, and so on. They are very widespread in their efficacy, and perhaps we'll see them with more than the 13 indications of some of our TNF inhibitors.
Where do you think the specialty is going? If you had a look, I won't even use 10 years because I think things are changing so rapidly. But over the next, 5 to 6 years, where do you think we're going to be going in rheumatoid arthritis?
Well, the one characteristic of all our patients is there's a very long prodromal period where they have autoimmunity. They have, and in the case of rheumatoid, they have localized autoimmunity in their mouth, their gut, their lungs. And we increasingly are able to pick up patients at that stage, and we've just recently validated the risk score of these patients in a new population of 400. So we know not only which patients will get rheumatoid, but when they'll get it. We're now doing trials of quite interesting agents in these patients. I'd like to hope that even if we don't cure the disease, we might slow it down a bit. So I think it will become fairly routine to be seeing patients in the pre-disease phase and hopefully stabilizing disease at that stage.
On a practical issue, in the United States, we've seen a significant reduction in total requirement for total joint arthroplasty in our patients with RA. I assume you're seeing similar reductions in the UK.
Yes, there's the best data have come from Scandinavia, but it's true. And the timing of, to be fair, that there was an improvement almost slightly before, but I think two things have happened. One, we've had these agents which are very good at preventing damage, but it's also made us much less tolerant of leaving patients with active disease. So the targets have improved enormously. And yes, as a consequence, joint replacement for rheumatoid has gone right down the list. I think it's way behind revision arthroplasty.
What do you think the great challenges are now in the management of patients with RA?
I think it's still, well, ideally, as I said, I would love to show that prevention actually works. We've got to accept it may not, but I think it will still get patients treated very quickly. I think that will improve remission rates and would also allow us to get patients onto smaller amounts of therapy. The thing that really is striking is there are still a sizable proportion of patients who end up resistant to all therapies. I think if we get better at treating early, that will reduce, but identifying the truly resistant patients early, I think, is the other aspect of it. And so people are concentrating on the features that allow you to identify those, and perhaps identify those who should get different types of therapy early, B-cell depletion therapy earlier. But I think the big change will come when we actually see all our patients and don't tolerate anything but remission or near remission in the first 6 months.
Do you tell your patients that your expectation is that you'll be able to stop drug therapy, or do you think most of these patients are going to require some background treatment, particularly if they're autoantibody positive? What's your view about that?
Well, if I told them they were going to be off therapy, in the majority of cases, I'd be telling them lies. So I'm usually truthful with them and say that they have a treatable disease. The chance of them getting into remission is now much higher. It should be higher than 50%, and then with aggressive therapy, it's higher than that. And that if we get them into remission early, they have a chance of reducing their therapy and possibly even stopping it. But stopping is still, in true rheumatoid, as opposed to people with joint pain, is still rare. It's 5 to 10% of even the best studies.
Mm-hmm. Is there anything else you'd like to tell the audience?
No, I think rheumatology has been a fantastic experience. I started over 40 years ago when everybody came to the clinic in an ambulance or a wheelchair. We had penicillamine and gold, and all we could do was minimize the side effects. You and I have been extremely lucky to be part of the revolution that's occurred in therapy for rheumatoid. And rheumatoid has been the model for non-infectious inflammation, and drugs that have been started in rheumatoid have been effective in a lot of other areas. So we've had a huge experience. And as part of that, the whole thing's expanded. I've been lucky enough to train over 30 professors and associate professors and hundreds of trainees. And it's wonderful seeing these people all around the world doing and being very excited by their work, which is, I think, the most important thing, and exciting people about research.
So it's, when I was looking through your resume, it brought back a memory that we did one of the first combination biologic synthetic studies, I don't know, 30 years ago, when we combined gamma interferon with D-penicillamine.
Yeah.
Two terrible drugs. But the idea back then of combining a synthetic with a biologic was not something people were terribly excited by. And look, today, I mean, routinely someone's on methotrexate or another synthetic, and a biologic or a JAK inhibitor is being added to it. So, I think what you've done in your 40 years of research has changed the field of rheumatology, and it's been a great pleasure talking to you this morning.
I just remember, Mike, that study, that's where the placebo had over 50% response rate.
Yeah, and it was important to be able to tell people that if you start to inject people, you better expect a higher placebo rate because of the injection.
Yeah.
So,
well, thanks very much for this conversation.